Welcome back to The Explainer. You know, it's wild to think about, but every single year, hospitals literally bleed millions in legitimate revenue because of one incredibly preventable issue. Today, we're putting on our clinical diagnostician hats, but we aren't treating patients. We're diagnosing one of the most notorious headaches in revenue cycle management, the CO97 denial. I'm stepping in as your senior RCM educator today, and we're going to lock down the strict billing protocols you need to not just resolve, but totally prevent this massive revenue leak.
Here's the game plan for this explainer. We're going to decode the CO97 denial, navigate through those tricky NCCI edits, review the key remark codes you need to know, map out an exact action flow, and wrap up with some rock-solid proactive prevention strategies.
All right, let's dive into Section 1, the symptom, decoding denial code CO:97.
Now, right off the bat, we've got to clear something up, the difference between an administrative rejection and a true medical denial. Think of a claim rejection as a pre-adjudication bouncer at the door. It's a simple formatting glitch, a typo, or a data error that stops the claim from ever entering the payer's system. It never even officially starts processing. A claim denial, on the other hand, that's a post-adjudication roadblock. The claim got past the bouncer, it was formatted perfectly, it entered the system, but after review, the payer officially said nope due to a policy or coverage issue. And as you well know, a denial is a whole lot harder to overturn. Which brings us straight to our main symptom today, Claim Adjustment Reason Code 97. CO97 basically means the payer is telling you, hey, the benefit for this service is already included in the payment for another procedure we've adjudicated. The absolutely crucial thing to grasp here is the difference between a genuinely distinct service and one that is inherently included. Look, if you bill for a major comprehensive surgery, the routine post-op pain management, or the surgical approach, that's inherently baked into the main code's payment. The payers are simply not going to pay you twice for the same pie. So what actually triggers this symptom? Well, unbundling is usually the prime suspect, billing out services separately when they totally belong under one comprehensive umbrella code. Close behind that is missing or just flat-out invalid modifiers like your -25 or -59. But it doesn't stop there. Global period billing violations, accidentally double billing for the exact same date of service, completely ignoring NCCI edits, or simply not having the clinical documentation to back up a distinct service, any of these will trigger a CO97 denial faster than you can blink.
Moving right along to Section 2, the underlying pathology, navigating the NCCI edits. To understand why these denials happen on a systemic level, we've got to look at the payer's ultimate playbook, the National Correct Coding Initiative, or NCCI edits. NCCI rules essentially dictate when separately billed services are inherently bundled as tiny components of a much bigger primary procedure. It's basically a massive, strict matching system. Picture Column 1 holding your comprehensive code, and Column 2 holding the component code. If you try to bill both for the same patient on the exact same day, the NCCI edit mechanisms wake up and flag them. They'll either say, hey, these are mutually exclusive, they literally couldn't happen together, or they'll flag them as a component pair, blocking separate payment unless you have a clinically justified override modifier.
Next up, Section 3, key bundling remark codes.
When that CO97 denial hits your electronic remittance advice, the attached remittance advice remark codes act like a magnifying glass, pointing you to the exact underlying pathology. Let's break them down. M15 tells you point blank that your separately billed services got bundled because they're viewed as components of the same procedure. N19, that means the code was just incidental to the main event. N20 is a hard, glaring stop. It means the service is straight up not payable alongside another service rendered on that exact same date. And then you have N357, which flags that specific time frame requirements between related services just weren't met. This is exactly how you read the payer's mind and figure out the rationale for same-day bundling.
Let's bring this into the real world. Now, as you can see here, trying to tack a modifier 25 onto an EM visit right alongside an appendix removal, like CPT 449070, without crystal clear justification is a classic trap. But let's look at another incredibly common scenario. Injections. Imagine building an EM code CPT 99214 for $216, alongside a therapeutic injection, CPT 96372 for $33, and some ketorolac, J1885 for $160. Suddenly, your remittance drops. The 99214 gets denied under CO97 for $125.08, leaving a CO45 adjustment of $90.92. Why did that happen? because NCCI validation sees that 99214 as a column 2 component of the injection. To legally and successfully override this, your documentation has to practically scream that a significant, totally separate evaluation happened before you ever append that modifier 25. The golden rule? Valid usage means the provider's documentation absolutely must support that distinct evaluation before the billing even happens.
All right, let's get into Section 4, the treatment plan, the CO97 action flow. So how do we fix it? Start with Path 1. You claim denied for CO97, but you look and hey, a modifier was already added to the unbundled code. First things first, you've got to validate the NCCI edits and those payer-specific medical policies. If your deep dive shows that the modifier is actually clinically allowed and your documentation backs it up, your treatment plan is to aggressively send that claim back for reprocessing or appeal it with the proof. But on the flip side, if you realize the service is inherently bundled per NCCI, meaning a modifier is literally never allowed for that specific code pair, you just have to send it for adjustment approval. You're essentially taking the write-off and referencing the policy.
Now let's look at Path 2, the claim denied. And upon review, you spot the issue right away. A modifier was missing. Good news, this is a highly treatable scenario, as long as the clinical truth is on your side. Step 1. Check your NCCI edit tables and dive straight into the provider's clinical notes. Step 2. If those notes explicitly prove a distinct, separate service occurred, maybe it was at a different anatomical site or during a totally different session, then go ahead and append the appropriate modifier, like a 59. Step 3. Refile that corrected claim. But remember the catch here. The clinical documentation has to validate the modifier. You absolutely cannot just slap a modifier on a claim hoping to get paid.
Finally, we arrive at Section 5, Preventative Care, Proactive Prevention Strategies.
Look, fixing denials after the fact is great, but you can't just treat your way out of a systemic issue. You need strict manual prevention protocols to stop CO97 in its tracks before a claim even goes out the door. First up, you need robust pre-bill reviews and internal audits specifically designed to catch unbundling. Checking those NCCI tables and global surgical periods, that has to become a mandatory, non-negotiable step before billing. We also need continuous, ongoing coder education, especially diving into the tricky nuances of modifiers 25 and 59. And maybe most importantly, we need serious cross-department alignment. Providers and billing staff have to talk to each other so that the clinical notes are hyper-detailed about distinct sites, different times, or separate incisions. That is what legally supports your unbundling.
But to really scale your prevention efforts, you've got to layer some heavy-hitting technology over those manual protocols. You should absolutely be leveraging automated claim scrubber tools. These are fantastic for automatically flagging unbundled codes or missing modifiers before the claim even leaves the building. You also want to look into tight EHR and EMR integration, using built-in templates and hard stops to actually force providers to document the required details if they're doing multiple procedures. And don't sleep on coding compliance software or AI billing rule engines that give your team real-time NCCI and modifier guidance. Finally, lean into robust denial analytics. You've got to be tracking these CO97 trends by specific providers, departments, or high-risk CPT codes so you know exactly where to target your training.
So as we wrap up this explainer, I want to leave you with a tough question to really assess your organization's revenue cycle maturity. Are your RCM workflows just reacting to CO97 denials, fighting them one by one in the trenches? Or are you actively utilizing targeted analytics, comprehensive education, and automated claim scrubbers to stop this revenue leakage entirely at the source? It's time to stop playing defense and shift from reactive to proactive. Decode Healthcare with Harshal.